on our OSA and CVD risk tonight with our special guest. You already know her and love her, our sweet queen, Carissa Hankins. So without further ado, you're going to shed some light on the new article that came out recently. And I'm so excited to hear all about it.
Excellent. Awesome. Yes, indeed. So thank you so much, Jen. When you first brought this article up to my attention, I was like, wow, it really sounds like sleep apnea is the skeleton in the heart's closet. But, as I looked a little closer, I was like, maybe there's some tweaking that I can do with that analogy. So here is the article, and I've included the link right here, because a lot of times the things that connection between the heart and sleep apnea, there are things we might not be aware of. Sleep apnea likes to hang out in the background, and sometimes people think it's just snoring. Some people, they want it to be just snoring, but it's not. And what if it's making them miserable and they just aren't connecting the dots? So I was curious about where we stand as far as the top 10 causes of death in the United States. And the 2019 numbers are the newest numbers that are out there. And when I was in nursing school 15-ish years ago, the order of these was a little bit different. But you'll notice that heart disease and cancer top the list. What I noticed was that it's actually solidly the top 8 of these causes are implicated with sleep apnea in some way, shape, or form. And you're like, what? Oh no, that's not good. And that's pretty scary that we might not recognize something like that as messing with our hearts and our brains and our kidneys, our pancreas, and it can increase our risk of death from cancer or car accidents. And people will say all the time, or quite regularly, well, I'm a safe driver. And I'm like, I know you're a safe driver. I believe you're a safe driver. But if you're going to have some kind of a catastrophic health event and you're behind the wheel, it's not going to wait until you pull over to happen. So the other thing with sleep apnea is the risk for what we call micro sleeps. And that's where the brain steals sleep 10 to 15 seconds at a time. And that's enough time to end up into oncoming traffic. That's enough time to end up having hit a telephone pole. So even the people who proclaim their safety of driving, even when they don't feel like they have an alertness issue, there is still a risk there when it comes to accidental or unintentional injuries, which is where I envision the number 3 cause of death in 2019 came from. So I like to think of health as a house. I mean, how many people of here watching this are homeowners? I don't know about your fix-it list, but mine doesn't seem to get any shorter no matter how many things we get done. It just doesn't. So the main difference between actually a house and your health is you can't just buy a new one if you don't like the old one. You got to take care of it. And it's up to me as a homeowner to fix those things that are starting to need repairs. I don't want to wait until I have a big problem before I start doing something about it, because the longer I wait, the more damage there's going to be, the more cost there's going to be. I want to get at it while it's small. And I think the same principle holds true for the house of health. And I would like to look at it in 3 different ways. So these ways would be our levels of primary prevention. And, so levels of prevention. So primary prevention is exactly what it sounds like. It's taking measures to make sure that a health problem never happens. And it's one of the many stones in the shoe of the vaccine debate going on right now. Like one of the arguments is, well, I didn't get sick, or I'm not going to get sick, or I don't think, it's going to be that big of a deal. But primary prevention prevents that. So when we're talking about a house and primary prevention, that would be like keeping on your heat overnight so your pipes don't freeze when the temperature drops. pipes. Another example would be getting all the water out of your pipes when you leave on vacation in the winter. So again, your pipes don't freeze. And this sort of stuff makes leaks and water damage a non-issue from burst pipes because it never happens. And you might think you might be wasting money by keeping your heat on, even if it's turned down, but you're actually saving burst pipes and water damage. You never see them. And so you're taking measures to make sure it never happens. And this is where maintaining healthy habits and diet and weight can pay off for some people. And I think it's true with sleep apnea risk as well as the other top issues that affect the heart. So primary prevention, that's aim is to stop a problem before it even starts. Secondary prevention is early detection and getting at problems before they get worse. So earlier this year, my husband replaced all of the plumbing in our house. We went from copper to PEX. PEX is a kind of plastic. And he knew it was something that needed doing because he went down in the basement one day and he noticed there was water on the floor where it shouldn't be. So he's like, oh, there's water there. And he stands up. He gets nailed in the face with water coming from a pinhole in one of the copper pipes. And of course, we're like, well, that ain't good. And the pipes had degraded so much, he didn't even need tools to take them out. They just crumbled in his hands, a lot of them. So he made sure to replace the pipes going to the second floor because he knew if those started going, that we might have leaks inside the walls, and then our very small problem would be worse. So, whoops, I went the wrong way on my slide. Let's go forward. So when we're talking about sleep apnea, secondary prevention means screening and early detection. Is that snoring just snoring? Is that nap requirement just old age or stress or medication side effect? It's always a good idea to stop, look, and listen to clues that sleep apnea may be present. And I know that's a play on words and it's a song, stop, look, and listen, but stop refers to the stop bang screening. So that means snoring. Do we snore really loud? Tired. Are we more tired than we should be? O is observed apnea. So are people seeing that you're not breathing right when you're sleeping? P is for pressure or high blood pressure. So either blood pressure that's not cooperating or just having high blood pressure in general. Bang is BMI over 35, age over 40 or 50, depending on how you interpret the tool. Neck size over 16 inches in women, over 17 inches in men, and gender, which it favors male gender. But I always have that caveat that our ladies after menopause also have an increased risk. So that's stop. Look means look at your patient, look at their airway, look at their face and neck and jaw, and look at kind of how they're put together because you're probably going to see clues to is sleep apnea there. Mall and potty scoring is a quick assessment of airway crowding. So you just have someone open their mouth and see how far back can you see. If I'm on the fence about somebody needing sleep testing, if I'm on the fence about their risk for sleep apnea, then sometimes just looking in their mouth, that can really seal the deal as far as do we really need to send them, or should we possibly be looking in other places? And then listen is exactly what it sounds like, listening to what the patient is telling us. Also listening to what the medical record says, because there's a lot of clues in that medical record for the detection of sleep apnea and some of the downstream consequences or coincidences that tend to go along with it. And, I've been doing this long enough to recognize sleep apnea risks all over the place. So I know it's how I know sleep apnea has ties to those top 8 causes of death on the CDC's 2019 list. What happens when we're past early detection and screening? What then? Well, that's where we get to tertiary prevention. And sometimes we don't see the signs of an issue until there are big problems in our house. So you can think of tertiary prevention like when there's water coming from the ceiling. Maybe we missed the signs. Maybe we ignored the signs. That puddle was always there, right? regardless of how we got here, these issues that need to be are things that need to be dealt with right away before there's major damage. And every minute you waste means more time and more money and more misery. I might not know exactly where the water is coming from, but I'm gonna grab a bucket and I'm gonna move some furniture out of the way. And if I think it's coming from a pipe, I'm gonna turn off the water. Maybe the tub upstairs is overflowing and there's chunks of ceiling plaster falling onto the dining room table. That is a true story, by the way. Maybe the roof is leaking. And I think we can all agree that these big issues will be things like heart attack and stroke and pulmonary hypertension, whether or not it progresses to cor pulmonale, right heart failure, regular heart failure, atrial fibrillation. All of these things can cause disability and mortality. But the question I always ask is, could untreated sleep apnea be a contributor? And that's really where this article shines. So let's jump into the AHA statement. So the American Heart Association has, through their scientific statement, has screening recommendations for sleep apnea. So they know, based on the volume of data that we have thus far, that in these scenarios, you're likely to find sleep apnea. You're more likely to find sleep apnea than you would be in somebody who didn't have any of these. And so we're going to run through the vast majority of these as we go through our presentation tonight. And I like to think of these guys as sleep apnea's friends. I know, you're like, sleep apnea has friends and they're important? Yeah, I think so. And, you know, they might be sleep apnea's friends, but they're bullies to us because they don't mind messing with us. They don't mind making us miserable. And, you know, nothing good comes out of not breathing right at night. And not all of sleep apnea's friends are caused by sleep apnea. Some of them, they just like to hang out together a lot. And, you know, you might want to think of sleep apnea's friends like the life of the party, like, oh yeah, whoa, you know, kind of obvious. But tertiary prevention is what we strive for when disease is already present, because we want to reduce disability, delay or limit complications, restore function as much as possible. So let's look at some examples of that directly from the article. So sleep apnea and hypertension. 30 to 50% of patients with hypertension also have sleep apnea. And that one doesn't really seem to matter whether the hypertension is controlled or not. So can you imagine 30 to 50% of your hypertension patients having sleep apnea? That's a lot of people. We think up to 80% of hypertension, of patients with resistant hypertension, have sleep apnea. So these are people on multiple medications and the meds just aren't working. I had one guy, he was going for, I believe it was cataract surgery, and his blood pressure, no fake, was like 210 over 100. And he was already on like 4 meds and it wasn't working. And he couldn't get his surgery because nobody's going to do elective surgery on somebody with a blood pressure that high. And turns out he had sleep apnea. He didn't even know that he felt bad. He just thought he was kind of getting old. He didn't know until we got him diagnosed and treated. And then his blood pressure, it magically cooperated with the meds. It's not necessarily a cause or consequence of sleep apnea, but they do have some sort of a connection. And I know some people would be like, OMG, like my patient just got diagnosed with sleep apnea. Do I need to mess with their blood pressure meds? And the answer is no. Some folks will have some hypotension when we get them on therapy, but for the most part, I don't see where in clinical practice that we need to be super concerned about hypotension when we're putting somebody on treatment for sleep apnea. So speaking of hypertension, there's also pulmonary hypertension. Pulmonary hypertension and sleep apnea definitely go together. And the statistics cited by the American Heart Association specifies that the diagnosis of pulmonary hypertension that they were looking at was arrived at through right heart cath. So not the screening echo, but the legit, we manually measured the pressures inside all of the major blood vessels in the heart where, you know, we can test for that that sort of thing. 70 to 80% of people who had pulmonary hypertension on heart cath also had sleep apnea. And the reason we think this is so, or the mechanism by which we think this, is that mechanism of pulmonary hypoxic vasoconstriction. So oxygen goes down, the pulmonary blood vessels go, and then the right side of the heart does not like to work very hard. So when the blood vessels do this, the right side of the heart has to work harder to get the blood through the lungs and to the left side so it can do what it needs to do. And we think, sleep apnea and that hypoxic vasoconstriction is a part of that pathology there. So if we can prevent the hypoxemia, so the blood vessels stop vasoconstricting, then that can be helpful for our patients with pulmonary hypertension. Now, you might wonder why I have an ice cream cone dancing on this slide, and that's because pulmonary hypertension comes in multiple flavors. And you can have multiple flavors all at the same time. The flavor associated with sleep apnea, the pulmonary artery pressures tend to be mildly or modestly elevated. So those pressures usually 25 to 30. In the other versions of pulmonary hypertension, they can go much higher, 60, 80 millimeters of mercury. Pulmonary vasculature is supposed to be a low pressure system. And so once you get into some of those other variations, it goes up quite a bit higher, but you can have significant overlap. So any of my patients who have pulmonary hypertension, I'm always like, oh my gosh, we really need to make sure that there's not a hypoxic contributor to their heart issue. Because if one of the goals is, I want to not be as short of breath during the day, then this is the treatment target. Making sure that any underlying sleep apnea is treated. All right, sleep apnea, AFib, and others. So sleep apnea is independent risk factor for AFib. Multiple strokes, mortality, also some of the dementia syndromes. I didn't realize this, but post-stroke, there's a sleep apnea prevalence of 71%. We don't quite have the data yet, I think, on treating sleep apnea in the post-stroke community. It's tough. If you have somebody who's had a stroke and they have some cognitive issues that are going with it and some disability that are going with it, CPAP therapy might be prohibitively difficult in that sort of a scenario. So I think the data is still in progress on that. But back to other heart things, it's not unusual to have low heart rate and even long sinus pauses in the setting of sleep apnea. Now, and I'd had a couple of patients in the lab who had long sinus pauses, and they got invited to spend their day in the ICU while other things were in motion to make sure that they wouldn't have more than a pause, and to also get their sleep apnea treated. So sudden cardiac death predictors are sleep apnea number over 30, so AHI over 30, age over 60, and an average nocturnal oxygen saturation less than 78%. So that's the crowd that the data is showing are most likely to have sudden cardiac death. All right, heart failure and coronary artery disease. So this is all about our pipes and our pump. And heart failure is interesting because a lot of heart failure patients have sleep apnea, but it could be obstructive sleep apnea or it could be central sleep apnea. So obstructive sleep apnea, airway blocks off, they're trying to breathe, they can't get the air in. Central sleep apnea, seems to be a relationship between the development of central sleep apnea and the left ventricular ejection fraction. So if you have somebody whose LV is low, LVEF is low, and they have some central sleep apnea going on, if it gets treated, the heart failure piece, the sleep apnea can go away in that scenario. The obstructive sleep apnea tends to stick around regardless, but that central piece, not so much. I had a guy, it was last summer actually, he came in, his family was like, he is not breathing right. He's just not. And he wasn't a huge snorer. And on exam, he had a fast but irregular heartbeat. And it turned out he was in AFib with RVR. And we know that when you're in atrial fibrillation, you lose 30% of your atrial kick. So he also had significant heart failure going along with it. He got to be a guest of our facility for several days while the workup was done and various things were done for him medically. You don't want to have sleep apnea and heart failure because you get worse outcomes that way. And those outcomes are things like heart failure related symptom progression, hospitalization, and mortality. Now, coronary artery disease is basically clogged pipes in the blood vessels of the heart muscle. And sleep apnea triggers inflammation and oxidative stress. So those pipes, they clog up faster. Sleep apnea increases the risk for cardiovascular events and sudden cardiac death. And it's another kind of scenario where you don't want to have sleep apnea in the setting of like a heart attack because the 18-month event-free survival is worse than somebody who doesn't have sleep apnea in the first place. So there are a few other friends that sleep apnea has, and we're not going to talk about them tonight, but the thing I wanted to wrap up with is the connection between sleep apnea and death from heart problems or any other cause of death. Treating sleep apnea with CPAP does show a mortality benefit, but it showed up late in the data. It took 6 or 7 years to show up, like that research signal to show up. There is also a benefit for increased risk reduction when it comes to heart failure, which that's always a good thing. So we all want a house that is dry and welcoming. And I don't think anybody wakes up and says, I want to have a heart attack today, or I'd like to go to the hospital today and get admitted. That sounds like fun. Nobody wants to have to deal with shortness of breath or AFib or pulmonary hypertension or the consequences of stroke or heart failure. And it's not just the risk of death from these things, it's the disability risk. It's how it messes up our health house. And it's not all that different from when my husband didn't want to have to deal with more plumbing issues than we already had. And of course, now that the plumbing issue is taken care of, I don't have to worry about it because it's a non-issue. So I'm looking to prevent sleep apnea's friends from causing damage to my house. Some of that damage is fixable. Some of that damage is not fixable. And what we talked about today is just a small part of sleep apnea's story, how it relates to heart health. I mean, it can be sneaky, and just like some of the things that you may not already know about EKGs, and we can try to ignore it and deal with the consequences, or we can listen to what our hearts are trying to tell us about our health houses and do what we can to make things better. My goal for patients, whether they have sleep apnea or not, is that they may sleep better so they can feel better and do better. And so that's all I have for tonight, but I did score a couple of sessions in Jennifer's next 30-day challenge. So if you want to hear me talk more about sleep apnea, you can hit me up there. If you're already in our group and you want a specific topic for one of the upcoming lectures, let me know. We'll see if we can incorporate it in. I also have a Facebook page, the Sleep NP, which is mostly patient-centered, but providers and others are welcome there. And the bottom line is that our hearts are calling, trying to tell us what's going on behind the scenes. How will we answer?
That was